Good afternoon to all. We had a two powerful session from the two endocrinologists. You had on diabetes, two segments are there. Now the next topic is again an endocrinology topic, but it is discussed by a physician only. So it will be on the physician's level only we will be discussing. Okay. In fact, hypothyroidism is a second commonest endocrine disorder which is seen in the pregnancy. First, of course, the diabetes, gestational diabetes mellitus. It's in fact always a controversial and debatable topic. I'll be discussing the topic a little bit about the physiology of thyroid hormone and what changes, what hormonal changes that is happening in pregnancy, and what is the target of thyroid stimulating hormones level during pregnancy, and something about the management of diabetes. This is what normally you see. The hypothalamus, this is hypothalamus pituitary axis. Hypothalamus will be producing TRH, which acts on the anterior pituitary. Then from the anterior pituitary you will get a thyroid stimulating hormone which acts on the thyroid gland, which will produce free T3 and free T4 into the circulation. Then always there is a negative feedback is there. Whenever there is a high level of T3 and T4 in the circulation, that sends a signal back to the hypothalamus and pituitary, say no more secretion of the TSH. That is what normally happens. So, what changes that is happening in the pregnancy? Pregnancy always, it's a hypermetabolic stage where you need more of an energy. Basal metabolism is more of thyroid hormones are required. Your requirement is like 20 to 25% higher than the normal level. Basically, in the pregnant lady, the two hormones are playing a major role. One is HCG, which is secreted from the corpus luteum of the placenta, and another is the estrogen. When HCG is it's a glycoprotein which has got an alpha and beta subunit. The alpha subunit has got a structural similarity with alpha unit has got a structural similarity with FSH, LH and thyroid stimulating hormone. So it acts like a thyroid hormones. When HCG is more, what will happen is it stimulates the thyroid gland to produce more of a T3 and T4 into the circulation. When more of T3 and T4 in the circulation, what will happen? What we mentioned earlier, there is a negative feedback. You will get a low TSH. That is why pregnancy, why you get a low TSH, why you want to put the target lower down, because when the HCG is more, the TSH will be less. That is one thing. Second thing happening is there's a lot of estrogens are there throughout the pregnancy. The estrogen will act on the liver to produce more of a thyroid binding globulin. When the thyroid binding globulins are more, what will happen? Whatever the free T3, free T4 in the circulation, this will go and bind to the T3 and T4 in the circulation. Ultimately, what will happen is free hormones are less in the circulation. So these are the two things are happening. And a third thing is happening is if you are in an area like in a hilly area where iodine contents are less in their because of the habits. Now we don't have a problem because we are all getting the iodide salt. In pregnancy, the blood flow to the renal arteries are much more. So glomerular filtration rates are more in pregnancy. Then the more of thyroid hormones are, because of the increased GFR, eliminated through the circulation. So you require around 150 microgram more of iodine in your blood. So these are the basic changes that is happening. So the HCG will increase the thyroid function. When the thyroid T3 and T4 is elevated, see. When T3 and T4 is elevated, TSH naturally comes down. That is the one thing. Then hyperestrogenism, there's an increased thyroid binding globulins are there. Okay. This is a very important slide. You know, the first trimester of pregnancy, the HCG goes up. When somebody is having a hyperemesis gravidorum, HCG levels are much, much higher. Then there's a reciprocal things happen in the thyroid TSH, it will come down. There are a situation where you can get a transient hyperthyroidism also when there's a patient is having a hyperemesis gravidorum. Okay. But that HCG level comes back to normal by around 12 weeks of gestation, and again the TSH also comes back. So when you want to evaluate the patient about the thyroid hormone, in the first trimester, if you get a very low value, that means that is the period, the first trimester is the period the organogenesis happens. When the organogenesis happens, you need to supply sufficient amount of thyroid hormone because your basic metabolic rate is very high. That is why somebody comes, a pre-pregnant patient who was having a hypothyroidism, when they become pregnant, we know there is a requirement of the thyroid hormones are more. What usually it does is give a double dose, whatever they were taking in that weekends, Saturday and Sunday. Suppose somebody is on 100 micrograms of a thyroid hormone, thyroxine they were taking, the 20 to 25% of amount of thyroid hormones are additionally required for these people. So what I ask is take the 2 tablets on Saturday and Sunday, then continue the same thing. There are people who comes with I forgot to take the thyroid hormones today morning, take it in the afternoon. If they miss it, the next day they take 2 tablets. Because this has got a mechanism is like that, whatever you need is 1 week, whatever you require, you can supply. Even if you want, you can give whole sort of thyroid hormone for a week, they can take in a day. So there is no issue at all. So you can double the dose. This is what the hormonal changes happening is. Okay. This is what during the consumption you see the first 12 weeks. Up to the 12 weeks, you need 100% supply of thyroxine for the baby because baby's thyroid gland starts developing only by 12 weeks and sufficient amount of hormone is produced only by 20 weeks. Till 20 weeks, you need to supply with the thyroxine for these people. So this is what usually happens is this is the HCG. Okay, when HCG is going up by 10 weeks, HCG level goes up and gradually comes down. So opposite thing is happening is when HCG goes up, the thyroid hormones comes down. This is the. And another thing is this is what is you are showing is a thyroid globulin. Thyroid globulin level also increases throughout the pregnancy. It will remain high throughout the pregnancy. Along with that also, thyroxine level also goes up. This is not the free thyroxine. There's a combined thyroxine or a thyroxine bound thyroxines are elevated. This is what is happening in pregnancy. Okay. So finally, what is the increased estrogen will produce 2 to 3 times fold increase in thyroid binding globally. A structural similarity with the HCG will produce an increased amount of the T3, T4 levels are increased, transient hypothyroidism. This is what is important. You know, the demand, due to all those things, the demand of thyroxine will be increased throughout the pregnancy. Now, what is the prevalence of hypothyroidism? Prevalence, you know, what is you are taking as a cutoff point, that is the prevalence. If you take a cutoff point as a 4.5, that's usually you say 0.5 to 5 or 0.5 to 4.5, you take it as a normal people. If you take that as a cutoff point, the prevalence of hypothyroidism are 15.1. If you are taking bringing down the TSH value to 2.5, the prevalence goes up. So it's a huge problem. So whatever the cutoff value you are taking, is there any recommendation for a universal screening for these people? Somebody comes with all the diabetic, all the patients become pregnant. It's whether you want to do it thyroid stimulating hormone level. There is no universal recommendation, is not there. There what we do is what had been practiced, high risk people, people above the age of 30. Patient had undergone a thyroid surgery, patient had undergone a radiation or something, patient had a miscarriage, like autoimmune, other autoimmune disease, type 1 diabetes. These are the people which was recommended by the American Thyroid Society. But what the Indian guidelines says, all pregnant females should be screened in the first trimester for measuring the TSH level. So this is what we are supposed to follow. Because in USA, if you want to do a thyroid, what we are supposed to follow. Because in USA, if you want to do a thyroid stimulating hormones level, they may be very expensive. So that may be the reason they are put a criteria, high-risk people, so these are the people who should be undergone a thyroid stimulating hormone estimations. Okay. So our guideline is, anybody comes into the antenatal department, do a TSH value. So what are the complications you are anticipated if you don't treat a subclinical hypothyroidism? They can have problems with both the mother and the fetus. Both can happen. So mother can have anemia can be there, pregnancy-induced hypertension, miscarriage can be there, frequent abortions can be there, hypertension in the pregnancy is very important. There's an increased risk of, increase may not be the risk, LSES can be very much high. Okay. But the problem is here, whether the neurocognitive impairment, whether that can be corrected, that is the area of a debate is there. Okay. If you manage the patient's good control of hypothyroidism early in the pregnancy, whether the other things can be improved, whether the neurological complication, that was in the recent 3 randomized trials has come in the last 1 decade, that doesn't prove the beneficial effect of a neurological improvement. But in the past, it is like the patient's IQ, the 7-point IQ improvement, it was shown when somebody was treated, or there are people who like a hyperactive child, neurocognitive impairment. These are all, traditionally it was taught that there is an improvement of these problems if you treat sufficiently this patient with a subclinical hypothyroidism. Okay. This is the thyroid problems. You know, by the 8th week of gestation, the thyroid receptors appears in the baby. So that is the time receptors only appear, but you have to substitute the baby for these are up to 12 weeks, the organogenesis is there. The baby doesn't produce a thyroid hormone, but by 18 weeks a sufficient amount of thyroxine is there. Mind, the TSH doesn't crosses the placenta, TRH doesn't crosses the placenta, only thyroxine will crosses the placenta. Okay. But by 20 weeks, they will take care of their own problems taken care by the baby. Because baby, unless like a cretin child, basically thyroid hormone productions are low in these people, they may suffer. Otherwise, normal people, the thyroxine, whatever require for the mother, baby, the baby will take care of themselves. So, now what is the target? You see, when to treat. Because these are those always physicians gets a reference from a gynecologist. The TSH value is 5, TSH value is 6, what to do and all. Okay. There are clear-cut guidelines are there. But this is the guideline around 2017 only. Okay. ITS, Indian Thyroid Society, says first trimester keep the TSH 2.5, second trimester 3, and third trimester 3. Okay. European Thyroid Society also goes the same thing. But what happened is that American Thyroid Society has come out with a different explanation. Are we treating these people unnecessarily, or are we over-treating these people? What they said is, take a locally available, like a prevalence in Kottayam, how many people is having taken a group of people, their average TSH value in these people. That is what. So locally derived reference ranges are there. If you are not getting a localized reference range, upper limit of the cutoff is 4. That is what the American guideline, American Thyroid Association is giving 4. Okay. So guidelines all comes, it's 4. But what Indian guidelines is keep this 2.5, 3, 3.3. Even in Gujarat and all, there are some places in India, they have taken their own, like American guidelines, their own criteria of or prevalence of thyroid hormones they have taken. Okay. Now the problem, whether to treat. When you say subclinical hypothyroidism, you can see the TSH is elevated, T3 and T4 are within normal limit. When you say overt hypothyroidism, the TSH is elevated, T3 and T4 is low. This segment of people, definitely they require treatment, there is no doubt. This is the gray area where what to do, that we will see. What Indian guideline says, you should treat as subclinical hypothyroidism. Subclinical hypothyroidism has been shown to be associated with an adverse outcome for both mother and the fetus and should be treated with the thyroxine. That is the Indian guideline. Okay. This is the one study which is showing the beneficial or subclinical thyroidism Indian pregnant woman affects the maternal and fetal outcome. You see, this is one subclinical hypothyroidism. There is an increased incidence of anemia, increased incidence of PAH, and IUGR, IUD. Many are there. I am not showing all these things, but there is a problem if you don't treat subclinical hypothyroidism. That is an Indian study is showing. Okay. This is what. Definitely, those with the overt hypothyroidism, there is a very high incidence of pregnancy-induced hypertension, IUGR, IUD. There is definitely all 3 are there, and many more are there. Okay. So, overt hypothyroidism you should treat. Subclinical hypothyroidism also found to have the beneficial effect in anemia, pregnancy-induced hypertension. There are all the higher risks are there. This is the only situation what we come across in your clinical practice. Only this combination. If you see a thyroxine TSH levels are elevated, you can have a TSH elevated, free T4 down. That means you are dealing with a primary hypothyroidism. It is overt hypothyroidism. This is no question. The problem is in the thyroid gland. Second situation is the TSH is elevated, T4 is normal. You are dealing with a subclinical hypothyroidism. If you find a patient with TSH is low, T3, T4 is low, you think of a problem is in the higher up. it is in the pituitary or in the hypothalamus. So it's a central cause. So if you see a patient with a hypothyroidism, T3, T4 low, TSH is low, it is not the primary hypothyroidism, it's a problem is in the pituitary. Okay, so here also what you have to do is you think of other hormone which was producing from the anterior pituitary, you have to look for, like they may require a substitution with the testosterone, the FSH, LH, prolactin, all will be low in this situation. So that is what all is the situation. So now you are diagnosed as a case of a overt hypothyroidism. Usually what happened is somebody with an overt hypothyroidism, T3 may be, TSH may be 7 or 8. T3 and T4 is slightly low. That means they are overt hypothyroidism. They should be treated with a full dose. Not like starting with the 12.5, 25, because TSH is only 7, only 8. It is not like that. If you find that the patient is overt hypothyroidism, they should be treated with a dose of minimum 1.6. Like a 50 kg lady, they may require minimum 75 to 100, depends upon the weight. And the full replacement dose should be given, because you cannot wait, because that is the time the patient's organogenesis, all the complications sets in, then you increase 25. Don't do like that thing. That is the recommendation. You do a full replacement dose. Whatever the guidelines are given, that is fully for the diagnosis. There is a difference between Indian guideline and American guidelines are there. But for the target, they all recommend you keep in the first trimester 2.5, second trimester less than 3, third trimester less than. This should be the target. And somebody pre-pregnant, I already mentioned, there you should increase the dose by 20 to 25% to these people. By the time baby delivered, you immediately reduce to the pre-pregnant level. Say, suppose the patient had 100 microgram they were taking, and you have increased, and the weekend 2 tablets were increased. At the end of after the delivery, you reduce the dose to the pre-pregnant level. That's the only time why you supplied it. The demand was more during that time. So this is the recommendation, upper limit of the normal. Okay, 1 to 1.5. Always is like a 1.7 TSH level is there. You not based on your own calculation. You calculate based on the recommendation like 1.6, 1.71. Suppose the patient is having a subclinical hypothyroidism, you can start with a 1 microgram. Say 50 kg lady, you can start with a 50 microgram. But don't like a 12.5, 25. Like that, they should not be done. And what should be done? You have to test like every visit, maybe once a month you can do, or once in 6 weeks you have to do. This is the recommendation also. Should be tested 6 weeks to appropriate adjustment, because there is a problem. Even whenever you are treating, the patient, hyperthyroidism is not a cup of coffee for the physicians. It has to be sent to the endocrinologist, because because drug treatment, so many complications can happen in hyperthyroidism. So when you treat the patient, sometimes there's a fluctuation can happen. Patient may go into hyperthyroidism also. So regularly you check the patients. Okay. This is I'm coming to due to lack of time, I'm finishing soon, okay? This guideline, if you should remember. Somebody with a TSH of more than 10, no question, that is an overt hypothyroidism, that should be treated with a full dose. On the other end of the spectrum, somebody with a TSH value less than 2.5, no treatment. The problem is, this is the area. The patient with the TSH between 4 and 10, somebody comes to you. Here always you test for the anti-TPO antibody in these people. Somebody with a TSH value more than 4, less than 10, you should do anti-TPO. Then the next treatment is based on your anti-TPO positive or negativity. Okay. When anti-TPO, if you got a value of 5, suppose, and the anti-TPO is positive, there is no question that patient should be treated. Because the Hashimoto's thyroiditis, the autoimmune thyroiditis is the commonest cause of hypothyroidism in pregnancy. If the patient is having an anti-TPO antibody positivity, that patient should be treated. If the patient's, this is a recommendation is anti-TPO 4 to 10 and anti-TPO negative. There is a weak recommendation is there, you can treat it. If the patient had a miscarriage, patient may be on a IVF therapy or a high-risk patient, here again you can treat it. You can consider, it is like you consider treating. But this is a definite. Okay. Now, this is again the area between 2.5 and 4. That patient's anti-TPO negative, no treatment. Anti-TPO positive, then you look into the patient, what is their risk of the patient? Whether the patient had any previous autoimmune diseases, previous miscarriage, or it's a precious baby, something like that, or a patient is having an IVF or something, that patient should be treated. So this is the guideline. So American Thyroid Society has come out with this guideline. High risk woman, check the TSH as soon as the pregnancy is confirmed. TPO antibody if TSH is between 2.5 to 10. This is the ATA guideline, American Thyroid Society. Between 2.5 anti-TPO positivity, TSH 2.4. Here you consider therapy means depends upon the risk of the patient. Between 4 to 10, there is no question you should treat the patient. If TPO negative, 2.5 to 4, no treatment. And if it is 4 to 10, you can again consider the treatment. This is the classical recommendation given by the American Thyroid Society. And even an anti-TPO positive, if the TSH value even less than 2.5, some of the infertility specialists like Raju sir, they may consider treating the patient. Because in the future, this patient can develop an other autoimmune diseases, means it's like thyroiditis is like that. When even after delivery also, the patient go into thyrotoxic crisis, you can go for a transient period 3 months, because whatever the available the thyroid hormones that can be released immediately into the circulation, that also can happen. There don't treat with the propyl thyroxine and methyl thyroxine. These patients should be treated with a beta blocker only. Don't do it, because basically it is not a hyperthyroidism. Whatever the available thyroid hormones which is present in the glands, it is immediately released. That is autoimmune thyroiditis. Anti-TPO antibody is very, very important. So concluding the talk, this is a very, very important topics as far as the physicians are concerned. Just I have mentioned what is the target to be taken, and Indian guidelines says all the people with first trimester, anybody comes to you, you do a TSH value, and the Indian guideline says TSH value, keep it below 2.5. And whenever you are treating, treat with a full dose. And always you ask for a anti-TPO antibody when there is a TSH is between 2.5 to 5 to 10. Thank you.
Thank you, Sadakk sir, for an excellent talk. It's a very lucid, clear, starting from the basics to the intricacies. And the must point to be highlighted is a matter of fact talk. So, as Sir rightly pointed out, hypothyroidism in pregnancy, now as a fertility specialist, we do cater the more importance to the preconceptual care. Because when the patient gets into pregnancy with a bad thyroid state, obviously the outcome can be bad. So when we are dealing with so much recurrent pregnancy losses, miscarriages, and then finding out the patient is having hypothyroidism, so the implication is something called preconceptual care, making the lady in a better environment to conceive. So thyroid is an important tool in the preconceptual care, and the Indian thyroid guidelines was been endorsed by our gynec society, FOXY. That is why the first trimester routine screening for all pregnant ladies with TSH. And the topic is open for discussion, and I will initiate some questions. Sir, it's a common doubt for majority of the obstetricians once the patient is put on with thyroid supplementation. How you monitor the patient in 6 weeks interval with TSH alone or TSH with T3, T4 or TSH with FT4?
Guideline says everything is based on the TSH. Guideline says you keep the TSH below 2.5 or below 3 first or second trimester of the pregnancy. That guideline, even American guideline also, doesn't mention about the T3 and T4, but when the postpartum period, they are mentioning about the value of T3 and T4 to rule out a thyrotoxic crisis.
So we do somehow come up with a situation that the TSH will be normal, but the FT4 will be quite high. So we'll be in a little dilemma that whether to reduce the dose or not. What is your talking about?
That is, situations are there. That is a hyperthyroxemia, where TSH is normal. It's a very rare situation as such. That's what I can know. There, when the thyroxine levels goes up, I think you have to slightly reduce the dose. That's what.
Any questions?
Sir, compared to our Indian physician, what guidelines we are following, what you told. Okay, is there any data for complications who has followed American Diet Society?
This American data has come after 2017. 2017 guideline says, I just opened the topic like that things, what the Indian guideline and the American guideline. You can follow any of the things, but they keep the target, both the target. Diagnosis, this is the only that coming to the diagnosis. So finally what I have shown is the ATA guideline only. And now we are following that only. That is the ATA guideline says. So that is why it has come in 2014, I think.
Yeah, it is in 2018.
No, previous guideline.
14.
It was come in 2014.
Is there any difference developing the complications? Is the Indian guidelines you follow?
That Sir may
Yeah, so basically, as rightly pointed out, there are actually in the last decade, last 4 or 5 years, there are some studies which came up not showing an improvement, deteriorating the neurological development of the baby. Because previously, that common issue in treating a thyroid condition in pregnancy, telling that the patient IQ will be a little bad. But there are some studies proving that it is not doubt. But the problem is that there are a lot of other pregnancy-related complications like IUGR, preterm birth, neonatal complications has been associated with the hypothyroidism in pregnancy. So whether this may attribute to a further neurological sequelae is yet to proven. So since the pregnancy is a difficult condition, we have to treat the baby as well as the mother. It is always to have a better control of thyroid during the pregnancy stage, so that avoid complications can be prevented at a later stage, even though the present evidence is lacking on it. Yeah. So actually, Sir has already shown a slide regarding that, because one study he quoted is actually an Indian data on the prevalence of IUGR, the prevalence of PIH, and the neuropsychiatric development. So there is an Indian data prevailing to this also, because the Indian Thyroid Society guidelines has been endorsed by the FOXY. FOXY is the organization of the Gynecological Society of India. So there has proven drawback of hypothyroidism in pregnancy. I think I'm clearing your doubts.
In fact, regarding the neurological complication, in US there was a study conducted. What they done was they take the umbilical cord sample and they keep it for a period of 10 years. After 10 years, follow up these people, then only they found that the subclinical hypothyroidism patient, the normal people has approximately 107 is the IQ, and those people who had a hypothyroidism, because they can, from the umbilical cord you can check that amount of thyroxine in the TSH in these people, and they found that those people who had a subclinical hypothyroidism, about, this is done after 7 years, they showed a 7-point down the IQ in these people. Okay.
Wind up the session. Thanks.
I'd like to invite Dr. Rajiv Mohammed to present a moment.
Sir, one more. Sarin.
In fact, there is a recommendation also like that thing. But when this simple thing is that if the patients usually comes and ask, when you miss the dose, sir, I forgot to take in the morning sample, can I take in the afternoon? Or can I take in the night? To tell these people, even there is no complication, even if you combining or 2 or 3 days, that there is a recommendation is there. There is a recommendation is there. There's no doubt. Sharma sir? Okay.
Dr. Rajiv Mohammed to present a memento to Dr. Sadakkkathulla, sir. Dr. Anthony George Joseph to present a memento to Dr. Raju R. Nair. And Dr. Annama, HOD OBG KIMS, to present a memento to Dr. Rajiv Mohammed.